Now we will be moving on to our last segment of the session one, a panel discussion which will be moderated by the organizing committee members of the mini-symposium, Dr. Ahsan Ali Khan and Dr. Waqas Baqai. Dr. Ahsan is a senior instructor here at the Aga Khan University Hospital, having completed a fellowship in neurosurgical oncology. Dr. Baqai is a fellow of neurosurgical oncology at the Aga Khan University Hospital. The floor is yours, Dr. Ahsan and Dr. Waqas.
Thank you, Salar. Thank you. I must say I am really fascinated by the talks of Dr. Siddiqui and Dr. Knopps, and I just cannot wait to have my hands on this ultimate innovation in the field of radiology. So this comes to the panelist discussion, the title of which is the blessing in disguise for LMIC, this portable MRI. So I am glad that we are joined by Dr. Fatima Mubarak, Dr. Faisal Jahan, and Dr. Qalab Abbas. So a brief introduction for Dr. Fatima Mubarak. She is an experienced associate professor with a demonstrated history of working in the hospital and healthcare industry, skilled in MRI, clinical research, medical education, and advanced neuroimaging. She is also the first international outreach member of American Society of Neuroradiology from Pakistan and member of Asia-Oceania Regional Committee and the Quality Improvement Network of Radiology Society of North America. Dr. Faisal Jahan is a pediatrician and an epidemiologist with a decade of experience of conducting research in maternal, newborn, and child health in Pakistan, and currently she is working on Hyperfine Mri. Dr. Qalab Abbas,
and she is the chair of pediatrics.
Yes, true. Thank you. Dr. Qalab Abbas is a pediatric critical care physician currently working at the Aga Khan University, Pakistan, as the assistant professor and pediatrician. His interests lie in quality improvement in PICU and predictive analytics in critical care in resource-limited settings. So thank you, Dr. Qalab, Dr. Fyezah, and Dr. Fatima Mubarak for joining the panelists. So this brings to our discussion on the blessings in LMIC. So I would like to take Dr. Fatima Mubarak's opinion first. She is the experienced neuroradiologist here. So Dr. Fatima Mubarak, how do you see this as a blessing in LMIC?
Like I have seen patients undergoing Hyperfine MRI, especially like me and Dr. Aisha were there. So it's a very good experience. But the only thing which I was not able to see were the T2 flow voids on the stroke patients. And we have certain ideas that we can, Dr. Aisha must be here, that we can do something for the stroke patients, wake up strokes when we don't know when the stroke happened actually. Like we can see the T2 and flare mismatch in those patients. And I have also discussed this with the Eddie as well previously. So I see it has a good future in Pakistan with the Hyperfine machine, and the cases Dr. Eddie has shown us for the brain tumors, and I think I'm hopeful like it would be very helpful for the brain tumors as
well. Okay. Dr. Fyezah, would you like to comment on your experience so far?
Yes, sure. So clearly, I'm an outlier in this panel. Just to give you a background, my primary work is in maternal, newborn, and child health. And on this grant that we were working on, which is related to doing neurodevelopmental assessment of children, infants, 6 months and 1 year of age, where our funder, the Bill and Melinda Gates Foundation, and ourselves and other partners are working to devise a more objective way of doing neurodevelopmental assessment. So our work with Hyperfine MRI started based on this intention to eventually replace point of care MRI brain, which is simple to do, if we are able to replace it with doing a very difficult neurodevelopmental assessment, which is very challenging to do in community settings and in low resource settings. So that was sort of our goal of getting the Hyperfine here. But the overarching goal absolutely is that we want to create access, ease, as well as transform the way we do MRIs particularly in children, because as a pediatrician, and Qalab would agree that it is extremely challenging both for sick babies and for well babies to transport them in this huge MRI machine for an MRI brain. And looking at the brain is critical to pediatric clinical care, be it neurology, intensive care, surgery, whatever. So I really feel that having this machine here at AKU and working closely with the Hyperfine team and the support that we have from our funders is going to enable us to go through this transformation journey. My sense is that, there are people would say that, would this MRI replace a routine MRI? The answer is no. It will not be a replacement, but it can really transform bedside care, where clinicians usually take decisions based on gut feeling, based on surrogate markers, surrogate markers of brain function, of surrogate markers of cerebral edema, monitoring it through blood pressure, heart rate. So we can actually just on the bedside make these quick clinical decisions, because this machine it's cheap. It actually comes at zero cost. So the only cost is for buying the machine, and you have to give some support to technician support. But Hyperfine provides support for data analytics. And actually, I was in conversation with the funders it was last night, and they informed me that they have actually they're in consultation with a firm who is going to give us visualization. So there's going to be data visualization of all the images that we are taking, and it's going to be so user-friendly. They will give it in the hands of the users. And that just changes the prospect completely, right? So you may not even need an intermediary step of interpretation by a radiologist, which actually it adds to the workflow for both the radiologists as well as getting to a conclusion about them. So truly, I think it's amazing. It's amazing science, and I'm in this panel, so obviously I'm a huge proponent of it. But that's my 2 cents about it. Thank you.
Thank you, Dr. Fyezah. Dr. Qalab, as a pediatric intensivist, how do you see it as helping you there in the intensive care units?
Thanks, Waqas and the organizing team for inviting me. And I would begin by thanking Dr. Fyezah to provide us the access to this machine when it came to AKU. So when I came to know about the machine, and we were already kind of struggling to get imaging, especially in patients who are on the ventilator, on many vasopressor support, are already struggling from their clinical condition. So we started doing these scans, and as Dr. Aisha presented, this patient was admitted under my care in the pediatric intensive care. So I would just add to Dr. Aisha's presentation that if we would have done this scan in the ED, because currently we are only doing this in the critical care and the pediatric ward setting. If we would have done this in the ED setting, this patient might have been a candidate of thrombolytics, and the outcome might have been way better. I would like to quote a couple of more examples. There was a neonate who was planned for a complex congenital heart disease surgery, but there were some subtle clinical findings which made us thought that should we proceed to get this kid exposed to the cardiopulmonary bypass, because if there is a neurological injury which has been associated with the congenital heart disease, and if you expose them to cardiopulmonary bypass and cardiac surgery, that can worsen the neurological outcome. So we brought the machine to the bedside in the neonatal intensive care. We did the scan, and then we planned to defer the surgery. So this is another example of how we made a good decision, a good informed decision about the patient care. There was another a child who was admitted in the intensive care with non-traumatic coma, with a working diagnosis of tuberculous meningitis. And we had done an MRI which did not show, I mean, that showed the meningeal enhancement and all those things, but there was no hydrocephalus. And after adequate treatment, the child GCS was not improving. So we thought that instead of doing another MRI, we could do a hyperfine. And what we found is that there was significant hydrocephalus. And then we talked to our neurosurgery colleagues and got the EVD done. And as soon as the EVD was passed, the kid's GCS started improving. And then we also did a couple of follow-up scans to see and decide for the conversion of this to the VP shunt. So that's also another example of how at the bedside, we quickly made these decisions because the machine was accessible. There was no issues with the transportation, etc. And the patient continued to have their usual routine care, and the ventilator was working fine. The vasopressors were there, our nursing staffs were doing their thing, and then MRI technicians came, they did the scan. The parents also looked happy. So we have done around more than 50 scans so far, and each one of them is a story like this. So I think this is really a blessing in disguise. And as far as pediatric critical care medicine is concerned, because that's my specialty, so I think Hyperfine is gonna make an impact regarding the timely decision making, and also evaluating the therapeutic options in these children. It's definitely is a huge blessing for a country like ours, where getting an MRI in the public sector hospital, even in AKU, that's a problem because of the multiple issues of limited machine, longer time, and the inability to move the patients to the scan, as well as to get the need to get them sedated. But in the public sector hospital, sometimes the patient needs to be moved from one facility to another. So in such cases, this is going to be a game changer.
Thank you, Dr. Abbas and Dr. Faisal Jahan. You guys are doing an amazing job for the benefit of our population. So now, just like me, Dr. Ather is also eager to use this on our brain tumor patients. So I would like to ask Dr. Ather's perspective on utility of this low-field portable MRI in neuro-oncology and his overall review on this.
Thank you. So I've heard this in the last 2 hours. Everybody's first experience. Let me tell you my first-hand experience with this. So what did I do? I jumped onto the MRI machine myself and got an MRI myself. And it was such an easy task, this portable MRI. I didn't have to change my clothes. I was wearing jacket and everything. Put my head in there. I had to take my glasses off though. I did not need to take my watch off, and rest everything, my belt and all that thing. It was so easy. So let me show you my MRI. And I know nobody should start to judge me whether this is a bad, this is atrophy, or is there something wrong in here. But here I'm showing you my MRI, and I have the permission of Dr. Khan Siddiqui and Dr. Knopps, because I'm using that machine, and Dr. Faisal Jahan and Dr. Qalab Abbas, because this comes under their grant. So I have permission from all of you.
I do take a bit of
all right, so then here we go. So
the age.
What a beautiful brain I have. my medulla, I see my cerebellum coming up here. Petrous bones are okay. I can see the eighth nerve going into the internal auditory canal on both sides. My petrous bone is again healthy. Everything, cerebellum looks good. The middle cerebellar peduncle ventricles are fine. You know, there I see I see fifth trigeminal nerve, the fifth nerve. See this over here, and oh, sorry. So let me show you the. Okay, so this is my internal auditory canal on the left side, on the right side, and you can see the cochlea and the semicircular canals over here. Okay, and then as we are going up, the fourth ventricle is okay. I can see the basilar over here, and here I think this is the optic chiasm over here and the optic radiations. Okay, and this looks like left carotid, which is pretty good. Mammillary bodies over here, intrapedunclar cistern, colliculi, ambient cistern, all of them are good so far. Yeah. Okay, Sylvan fissure, little, I don't know. I mean, Dr. Fatima Mubarak, would you say that it's okay with age? You know, there's little wider Sylvan fissure on the left side.
I don't think so. It's your brain.
We go up further. The frontal horns are good. They're not dilated, so I won't have an NPH. Looks like I have a little septum pellucidum, cavum septum pellucidum, very, very minor probably. The splenium and the forceps major are okay. Yeah, the splenium is okay. Coming up again, ventricle is fine. And as we come up, and this is what I was teaching in the neuroradiology class. So this is my central sulcus. This is that omega sign thing. This is the precentral sulcus. This is the superior frontal sulcus on this side, and the post-central sulcus. Okay, I pass. So I don't think I have enough atrophy, or I don't think I have hydrocephalus, and I don't think I have any tumor over here, and there are no flare abnormalities. So I think I can function. But please don't use MRI to test whether a neurosurgeon can function or not, because you know that will be an issue. So that was my experience. So the reason I wanted to show this was it was so easy to get onto it, get it done, and you know, get back to your normal routine, and the ease of this portable MRI. So that was my personal experience, and I'm really interested in actually moving this into brain tumors, because we do get an MRI preoperatively, looking at all the images, DTIs, and so on, and then we do it postoperatively to see how much is left. We, as neurosurgeons, we have limited ourselves a lot to what we call as contrastectomy. So we look at contrast and we say, oh, this is the tumor. And you know, Dr. Knopps, he's a world-class neuroradiologist, and we were discussing it a while ago. You know, we have to think about the flare signal changes. So a lot of time when we remove the contrast, we leave a bunch of a high load of tumor behind. And actually the resection of the tumor depends on how much of those flare signals have you removed. And with the wake craniotomy, you can go into those areas and start to remove as much as possible. And when we follow up the patients, we see more, we follow more the flare changes than the contrast enhancement. That's typically what I do. Because with encephalomalacia, you will have this hyperintensity going around. But then what area of hyperintensity is starting to grow, and that's we know that there's a recurrence coming over there. That happens before the contrast starts to pick up. This is something that a lot of radiologists don't, and a lot of neurosurgeons don't understand or don't use it now over here. But this is where I think we should move towards that. Look for those flare changes early on before you start to see the contrast enhancement changes. And from that perspective, I think this is a wonderful thing to have this portable MRI, that we can repeat those MRIs as many times as we want. The reason that we don't do so many MRIs is because the MRI is not accessible and it's expensive. But if the accessibility is taken care of and if the affordability is taken care of, then I would like to have an MRI on my patients perhaps every month or maybe every 2 weeks if possible. and that will give me a very good idea. A lot of time I see patients coming up after falling for 3 years and there was no tumor recurrence, and then after that suddenly boom, there's a tumor recurrence that starts to show up, and there was a gap of about 6 months or a year. So with a portable MRI, I think we should be able to fill that gap and do more frequent MRIs. So I'm really looking forward to working on that one. Thank you.
Thank you, sir. So I have a question from Dr. Knopp. What do you see, as you said in your presentation, that it can also be used as neuronavigation. So what do you think would be potential challenges that we would face in utilizing the hyperfine MRI low field for neuronavigation?
So the primary difference between what you're accustomed to and this system is the fact typical high field neuronavigation sequences are isotropic. So they're equal in every dimension. We're anisotropic. So if you're targeting very small lesions, it may be difficult to actually target those lesions. Larger lesions, big ventricles, large clot you want to suck out, subdural, epidural, not a problem at all. That being said, there still is the ability to fuse the anisotropic image to your isotropic preoperative study as well, to give you an additional degree of more diagnostic accuracy. So again, it's all about the use case and understanding, and I think everyone understands the limitations of the system. As we said, it's not a replacement, but rather an adjunct to what you're using. If used in the appropriate setting, there's no question at all. Dr. Abbas had talked about patients with events blew up in the ICU, needed an EVD. You can use this guidance so you don't have to put an EVD in blindly, but do it at the bedside with image guidance because you have the scanner right there.
Right, that makes sense. Thank you. And another question from Dr. Khan Siddiqui. So Dr. Khan, in your vision, what is next? I mean, is there something after this that you are looking forward to? I mean, this is the ultimate thing, the portable MRI. So what do you think is next in this field of neuroradiology?
There's a lot more coming. I think I'm not going to steal our thunder here, but the things that are publicly known, we are also working on a non-invasive continuous cerebral blood flow monitor as well as intracranial pressure monitor device. It's ultrasound-based technology. Basically, the idea is the way you do electrical activity of the heart using EKG leads, have leads that do CBF and intracranial pressure continuously as a continuous waveform that doesn't exist in a non-invasive manner today. And again, same way that at a very affordable price point that could be on the patient all the time type of scenario. And then a lot of other work happening on the MR side of things with the Alcohol Unity Consortium and the sites developing different sequences, including working on isotropic data sets that Dr. Knopp talked about that would be helpful for surgical navigation and other techniques. A lot more to come. We're also thinking about the way we think about our Hyperfine is not an MRI company or a medical device company, but ultimately a care continuum company. So the thought process is that our products and solutions will follow the patient across the journey. So you will see evolution of technology where we're not only building the medical devices, but also the software and the clinical applications and the AI applications to actually help make the clinical decision at the bedside much easier and quicker to make and automate a lot of the process for those clinical decision making.
All right, thank you. So, Mr. Manya, do you have any comment before we conclude this panelist discussion?
No, thank you, Waqas. I think Dr. Eddy and Faisal Jahan and Qalab Abbas and Dr. Khan Siddiqui, I think they've done a wonderful job in addressing what the Hyperfine is and whether it's a blessing. I think conclusion is that it seems to be a great blessing. I'm just fortunate to be working with a panel like this in terms of bringing that this kind of revolution in healthcare diagnostics in Pakistan. So that's all I have to say about this.
There is a question from the, I think, public, our listeners that asking to Dr. Fyezah, Dr. Qalab, what about the perspective in terms of the research, and if they are doing any ongoing studies?
You want to go ahead, Dr. Fyezah?
She
Well,
asked you to do.
I briefly alluded to the reason why we got the Hyperfine machine into Pakistan. Basically, as part of a multi-center study, we have been able to create a biorepository of pregnant women and baby samples. And the aim of the biorepository was to look at use advanced omics technologies and multi-omics to determine signals which could predict poor neurodevelopment later on in life. The other trial that this Hyperfine is relevant to is nutritional interventions that we are doing during pregnancy, and trying to look at how those interventions can impact the newborn or the infant brain, and how that correlates with neurodevelopment. So like I said, doing psychometric testing in young children is extremely resource intensive. A lot of times it does not yield the results that you want because of poor validity of the test, poor applicability, differences in the way the testing is implemented and other things. So Hyperfine could be a route to look at objectively look at, for instance, things like brain volume, white matter volume, and all of those things, and to determine those changes to see how they can actually predict both early neurodevelopment as well as later on executive functioning. So those are the major research area in the community that we are working on using Hyperfine. But it's actually been great to work with Dr. Abbas on several other projects. So Qalab, you want to talk about the most recent one for which you got the ERC approval? So I think one is, yeah, go ahead, please.
Yeah, so we are doing a head-to-head comparison of the neuroimaging, whether it's a CT scan, standard or a standard MRI, and then the Hyperfine imaging. So what we are doing is that whenever a patient gets a CT scan or an MRI for whatever clinical condition as a part of the clinical care, we get a Hyperfine within 24 hours window period before or after. And our purpose is to see whether Hyperfine is able to pick the same findings as the CT or an MRI is doing. And then we are also trying to figure out somehow that how this Hyperfine can speed up the decision process as well as the intervention part. So this is ERC approved and this is in progress, and the 50-60 scans we have done so far are part of this current study, which is we are doing it mainly in the intensive care areas. Majority of the scans have been done in the pediatric intensive care. Some we have done in the pediatric ward as well as in the neonatal intensive care. And we plan that we will work with our ER colleagues, pediatric ER, and also start doing at some point start doing there. Another idea is which we are working with Dr. Kiran in radiology is to focus just on the hydrocephalus kids, whether it's a congenital hydrocephalus or a complication of meningitis in the early age. And because those patients require a lot of CT scan, repeated CT scans to see their brain growth as well as the status of hydrocephalus. And our purpose is to see whether Hyperfine can replace the CT scan, because it will be cheap, more easy, it will provide more information, and there will be no radiation, etc. So that's in the pipeline to come over.
Well, that sounds promising. Thank you, Dr. Qalab. Now, finally, I would take some comments from Dr. Ather for his views on the research perspective for this low-field portable MRI.
Thank you. I'm always inspired by what these pediatricians do in research. They're always ahead, and the public health aspect from the public health aspect. So as a chair of surgery, I aspire to bring the Department of Surgery, in, if not exactly like, but at least close to the research potential that the Department of Pediatrics have been doing. So actually, I'm planning to use this portable MRI and compare it with the MRI that we routinely get preoperatively and postoperatively for brain tumor patients. And my goal is that at one point we may be able to actually get rid of the high Tesla MRIs and just use these portable MRI that will cut down the cost so much. That's my goal, and maybe start to use it as an intraoperative MRI also. So there are some nuances and all that thing, and I have had a discussion with Dr. Eddie Knopps also. We are working on that area, and I look forward to starting this very soon, inshallah. Thank you.